Good morning and welcome to Grand Rounds for the Department of Medicine. Can everyone hear okay? I'm Tom Gallagher. I'm professor and associate chair of the Department for Quality and Patient Safety and co-director of the UW Medicine Center for Scholarship in Patient Care Quality and Safety. Today's a really exciting day for us as it's our annual UW Medicine Visiting Professorship in Patient Safety. The UW Medicine Visiting Professorship in Patient Safety is a collaboration between the UW Medicine Patient Safety and Quality Executive Committee, a clinical department, and this year the CMO's office. The goal of the visiting professorship is to bring an outstanding national leader to campus to stimulate our thinking about cutting-edge issues in patient safety. And while we've had many outstanding visiting professors over the year, this year's visiting professor, Dr. Tejal Gandhi, sets truly a new bar. Born in New York and raised in Maryland, Tejal received her undergraduate degree from Cornell, followed by medical school at Harvard, internal medicine residency at Duke, a general internal medicine fellowship and MPH at Harvard, after which she joined the Harvard faculty in 1999. At Harvard, she combined both a prolific research career with a keen interest in operational quality and safety issues, first at the Brigham and Women's Hospital, and later at the Partners system level, where up until 2013, she was the Chief Quality and Safety Officer. 2013 marked the year that Tejal became president and CEO of the National Patient Safety Foundation, a world-renowned organization committed to education and innovation in patient safety. Tejal's research has focused on several topics, including groundbreaking work on the epidemiology of adverse drug events and patient safety problems in ambulatory settings, as well as important work related to health IT. She's been the PI on multiple NIH R01s and has authored over 100 peer-reviewed papers. She's also received numerous honors, including the John Eisenberg Quality and Safety Award for Individual Research Accomplishments from the National Quality Forum and the Joint Commission in 1999, and just last year was named by Modern Healthcare as one of the top 100 most influential people in healthcare. On a personal note, having worked with Tejal on several projects over the years, I found her to be a truly delightful collaborator and extremely effective leader. Tejal will be speaking with us today on the important and timely topic of the interface between patient safety and population health. So please join me in welcoming Dr. Tejal Gandhi as this year's UW Medicine Visiting Professor in Patient Safety.
Thank you. Wow, thank you, Tom. That was quite an introduction, and I'm really excited to be here today, so thank you so much for the invitation to have me come. So I am going to talk about patient safety and population health, and really the goal of that is to sort of break down some silos. So, you know, I think we've often felt patient safety is over here, population health is over here, and they're separate and distinct, and often you'll see that structure in organizations, that they have different resources working on those two activities. And so the argument I'm going to make as I go through my talk is really the fact that they're integrally intertwined. And safety is really foundational to achieving what we want to achieve in population health. So despite the progress that we've made in patient safety, and I do believe we've made a lot of progress in patient safety, preventable harm remains unacceptably frequent. Varying studies have talked about it as a third, fourth, fifth leading cause of death. Lots of controversy about that data. But all of us who work in healthcare know that preventable harm is still happening, and any preventable harm is something that we want to make sure that we are trying to eliminate. Significant mortality, morbidity, quality of life implications, and really adversely affecting patients in all settings. This is not just a hospital issue, and I'll talk a bit about that as well. And as I just mentioned, patient safety is foundational to new priorities such as value or efficiency, reducing costs, any of that. Safety is critical, and also to population health and chronic disease management. So you all are familiar with the report to Erris Human, and what I was going to do in this talk today is kind of go through a report that we did about 1.5 years ago that was really an assessment of where have we been in patient safety and where do we need to go. And so we convened an expert panel and examined the state of patient safety 15 years after the release of To Erris Human, the seminal report. And really the impetus for this was I was getting so many inquiries from people about, are we safer now than we were in 1999? What have we accomplished? What has changed? And so on, especially at that anniversary. So we thought this convening and report would really help us lay out some of those things. So it was released in December 2015, and if anyone's interested, feel free to go check it out on our NPSF website. We did get endorsements of this report from a variety of organizations that I'll skip through quickly. And so what did we say in this report? So despite mixed evidence, and we can talk about that, the panel overall felt that healthcare is safer. We've achieved significant progress, particularly in key areas like infections and medication safety, surgical safety, but much more work needs to be done. And, you know, we didn't want to be overly discouraging either, because while we think progress has occurred but isn't as far as we want to go, we do think the progress is notable, especially for a very young field in healthcare. We're still working to develop scientific foundations, and it's received limited investment compared to other significant healthcare issues. So, and we all know too that this is a complicated problem. If this was an easy problem to solve, we would have solved it by now, but it is a complicated problem that's going to require a diversity of disciplines to solve. So one of the core precepts that we really talked about was the need for a total systems approach to safety. And what I mean by that is, I mean, if anyone here has run safety in a hospital, as I did for a long time, the approach often can be very piecemeal. It's, I kind of use the analogy of whack-a-mole, where, you know, something bad happens and you go deal with that, and then another thing happens and you're dealing with that, or you're reacting to some regulatory thing, or you're reacting to now a measure that you're getting penalized on, and it's very piecemeal. And what we talk about in this report is we can't lose sight of the need to take a wider approach beyond those kind of circumscribed initiatives, because even if you fix 10 of those things, we know that there's 100 other things that are also going on. And so you need to really build a foundation that we think is really based on things like culture and teamwork and communication and patient engagement that hopefully can spread through the organization and help with all of the issues, not just those few focused initiatives. So we had 8 recommendations in the report. I'll go through some pretty quickly, and I want to try to hone in on some that I think have perhaps more relevance to this population health connection that I'm going to be trying to make. So the 8 recommendations were: 1, ensure leaders establish and sustain a safety culture; 2, create centralized and coordinated oversight of patient safety; create a common set of safety metrics that are meaningful; increase funding for research in safety and implementation; address safety across the entire care continuum; support the healthcare workforce; partner with patients and families; and ensure technology is safe and optimized. So those were the 8 areas that we focused on and continue to focus on, and really have set kind of a guidance for what the National Patient Safety Foundation is focusing on as we go forward. So I talked about culture already when we talk about creating that foundation of a total systems approach. And I'm sure all of you have heard this term, safety culture. And, you know, it's really this idea that we are accountable for unprofessional conduct, but not punished for human mistakes. Errors are identified and mitigated proactively, and there's really strong feedback loops to enable learning from previous errors. And we've been working on this kind of culture in healthcare since Erris Human for a long time. When, you know, when that report came out, healthcare was incredibly punitive, and although I think it still can be punitive, we have made progress on this front. So, you know, this whole concept of the culture of safety came from other industries such as aviation and nuclear power, and really needs to be driven by leadership. And, you know, when we talk about culture, we often get this, well, that's pretty squishy, like what even are we talking about? And, but then there's also sort of this discussion that, you know, culture eats strategy for lunch, in the sense that you may have the best strategy, but if you don't have that right culture, you're never going to get anywhere. So for us, this is so foundational to anything else we're trying to do with safety. If people are afraid to speak up, if nothing happens when they do speak up, nothing improves, then you're really going to have challenges with your safety program. So there's some definitions here that you can read, but really it's the way we do things around here. And it's really shaped by leadership. So that's an area of focus for us is, you know, how do we kind of engage healthcare leadership to drive this kind of a culture? And this is another definition that I will leave up for a second so you can read. So as I said, we've been working on this for a while. And so I was actually kind of discouraged. This is going to project a little bit small for you, but AHRQ has a standardized culture survey instrument. A lot of hospitals in the country use the AHRQ instrument. Now they have a comparative database where they can actually show what data is looking like from hospitals around the country. And there's some areas where organizations, the reporters in these surveys say things are pretty good. Teamwork within units, for example, is at the top there, and it's % positive response, so pretty high. However, less than half, so about 40% or so, only 40% or so say that there's a non-punitive response to errors in their organization, and that bottom row, which surprised me because, like I said, we've been working on this for a long time. So clearly, there is still a lot of work to do to try to achieve the kind of culture that we have been talking about. So the other thing about culture that's really important is, you know, you can talk about culture, but you need actual strategies and tactics to change your culture. And so these are just examples of strategies and tactics that organizations are using to try to drive culture change. And you probably have seen these in your organization as well. Implementation of just culture algorithms, doing executive walk rounds so executives can really hear about safety issues from the front lines, reporting, safety reporting, and then feedback about what happens to those reports. Changing morbidity and mortality conferences to be more about systems than about individuals, huddles, and various educational efforts. So these are just examples of the kinds of things that we're seeing around culture. And then I'll go through this part pretty quickly, but I just want to highlight transparency as well, because Don Berwick, actually, who used to run CMS, founded the Institute for Healthcare Improvement, he talks about how transparency is actually the most important characteristic of a safe culture. And, you know, this ties to any effort you're trying to do. Are we transparent about what we're doing, and are we open to people talking about the problems and issues that they're seeing in that particular project, whether it's a surgical safety project, whether it's population health, whether it's improving efficiency in the OR? Are people comfortable speaking up and being transparent about what they're seeing and what concerns that they might have? I'm going fast through this because I want to make sure I get through some other pieces. So as you think about transparency, and as you think about safety and quality improvement, et cetera, think about these 4 interrelated domains of transparency. So transparency between clinicians and patients. You know, are we transparent if an error happens with patients? Do we have good shared decision making as you think about management of a chronic disease, where we're really transparent about risks and benefits of treatments, procedures, medications? Transparency among clinicians. So do you have good ways to compare data between clinicians to have good learning conversations about why are my rates of infection higher than yours, or why are your rates of diabetes HbA1c management better than mine, et cetera. And do you have the data, and then do you have forums where those conversations can happen? Transparency among organizations. This is actually an area that I think we need to do much better at, specifically, which is you all could be doing great work in an area, whatever it is, but often it's very much in your organization, and other organizations are reinventing that same wheel. So how do we share best practices across organizations about safety particularly? Because right now it's often very siloed, and then you have an adverse event here, you figure out how to solve it, fix it, prevent it, and then that same event could happen 2 miles down the road at another organization because we don't have good mechanisms for transparency and sharing. And then transparency with the public. This is kind of, this is here and going to grow exponentially in terms of what data does the public see, and how does the public use that data to make better decisions about their health care. I actually have a family member who is getting a knee replacement next week in a town that is not mine, not in Boston. And so as a physician, as someone who really understands quality and safety, it is really hard for me to figure out if her surgeon is actually good at knee replacements. And you'd think I'm pretty much the most empowered person out there. And we're sort of like, well, her doctor referred her to him, so he's probably fine. That's really not how we want ourselves, our family members, the public to be making decisions. So I think we need to be pushing towards more transparency about quality and safety data so people can make better decisions. Okay, number 2, I will go through quickly. This is about a centralized and coordinated approach to patient safety. This is a grid of, as I've been at the National Patient Safety Foundation, all of the organizations working on patient safety. And all of them are pushing recommendations to all of you. And there's not a lot of coordination, even at the federal level. If I think about AHRQ, I'll do alphabet soup here, AHRQ, CMS, CDC, NQF, who am I forgetting? Anyway, there's a bunch of different acronyms. And I actually talked to the leadership there, and I was like, well, at the federal level, how well do you guys coordinate on kind of what initiatives in safety you're trying to promote? And the answer was, well, we don't do it all that well. So I think, and a lot of people in this panel felt like we need to have better coordination. And it doesn't mean, a new federal agency or something like that, but just even if we set a couple of key goals that we're all working on together, as opposed to all of us having our own set of priorities, we would move forward faster. Number 3, a common set of safety metrics. And this really applies to, again, any project you're working on. Thinking about what is the best way to measure how this initiative is impacting patient safety. And thinking about metrics in safety has been really challenging. The usual metrics that we've been using in safety are hospital-based, which is, not terrible, but think about the entire continuum. We need to think about safety much more broadly, but generally based on either chart reviews, so very time consuming, or claims data, which we all know is not the greatest. So, a lot of the metrics that we're using in safety don't have a lot of value, especially to the people in the front lines and also to patients. So we have a lot of measurement challenges, and to turn the tide, the safety field really needs to establish standard metrics that span the entire care continuum. And what I really think we need to do as well is be more proactive. So right now in safety, we measure, okay, the bad thing happened, and now on chart review 3 months later, we figured it out, and now let's figure out how we can prevent that bad thing from happening. And instead, wouldn't it be much better to say, let's measure the risk, and this person has a high risk of something bad happening, and let's intervene before they actually experience that preventable adverse event. And so, I think with the new technologies and other things that are around, this is now in our grasp, where we can sort of highlight conditions. And the early warning systems and other things that are now out there are examples of this, where let's find the person who's at risk instead of 3 months after it happens, figure out what we're going to do to prevent it. And I think that's the direction we need to go in measurement. Let's see. So we need to think about also, as I said, measuring things outside of hospitals. You know, we focused on readmissions, infections, medication errors in hospitals, et cetera. But, you know, let's think about what is patient safety in a primary care practice and how do we measure that? Or in a, you know, cardiology practice or GI practice, we talk about ambulatory surgery, et cetera. What are the measures that are really safety measures in those settings? And then how do we capture patient-reported outcomes around safety? So these, I think, are going to be the questions we try to address as we go forward, while also keeping in mind we have to have measures that are useful and not overwhelming. So this is a big challenge. Number 4, and you know, Tom leads a lot of research in safety here at University of Washington, and we've seen, I think in our careers, the funding for safety research has continued to decline as opposed to, you know, going up. Yet there's so much more that we need to learn about safety hazards, especially across the continuum, and the best ways to prevent them. The NIH 2015 budget, about 3% was for patient safety. So again, if you buy into statistics about even, you know, top 10 leading cause of death, 3% seems pretty minimal. And it's really important to think about this as about understanding safety science. You know, what are the causes of harm? What are the strategies that are going to actually reduce harm? But also implementation science. And this is an area that doesn't get enough attention. We've seen plenty of studies of things like, for example, the surgical checklist. You know, great study that showed the surgical checklist reduced surgical complications, and then a bunch of follow-up studies that showed organizations who implemented it that had no impact on safety. And why is that? It's not because the tool was bad, it's because implementation was highly variable, maybe not done as well as it needed to be. It wasn't associated with leadership support and culture change. It was just, here's a checklist, go use it. You're not going to get the effects you need. So understanding the critical implementation pieces as well as the science piece is going to be really important. I just realized too, I've been skipping through these slides. These are all details from the report that I don't want to go through now, but I wanted to highlight, if anyone's interested in a deeper dive, there's tactics and rationales for all those tactics in the report for each of these recommendations. So they're there for you if you're interested. Okay. Number 5, addressing safety across the entire care continuum. And as Tom mentioned, this has been an area of interest for me for a long time. When I was at the Brigham early in my career, I was doing primary care, and it felt like every day in my primary care clinic there were things that were safety issues, and yet there was really very little research that had been done about what are the safety issues that are happening in settings like primary care. And we're not even just talking about primary care, right? We're talking about nursing homes, rehabs, ambulatory surgery, dialysis centers. All of these settings have their own unique safety issues. And the vast majority of the research that's been done has been in hospitals. The vast majority of care that is delivered in this country is not in hospitals. So we need better tools, processes, and structures to deliver care safely and evaluate safety in these various settings, and particularly in this current era where more and more care is being pushed out of hospitals for good reasons in most cases. We have to understand what the implications of that are for safety. So if you think about ambulatory care, clearly the safety issues in ambulatory are different than in hospitals. But here are some key differences that I want you to think about as you think about how you might even design safety interventions. And this, I think, ties in significantly to managing populations over time, et cetera. Because first of all, in ambulatory care, there's long feedback loops, right? So in the hospital, if I order a med and the patient gets an adverse drug event, you know about it pretty quickly. Nurses are going in, you're going in, and we know about adverse drug events in the hospital very quickly. In the outpatient setting, you can prescribe a medication, and 6 months later, the patient comes back, and then you realize they've been having a symptom for that entire 6-month period, which might have led to non-adherence or other potential issues that affect their long-term care. It's episodic, The signal to noise ratio is low. So again, in primary care, you might see a patient with chest pain, and maybe, you know, how do you find the 1 or 2 out of 50 that may be having cardiac chest pain, as opposed to in the hospital on the cardiology unit, you're pretty sure that it's a cardiac issue. Not always, but usually. It's widely distributed, limited resources and redundancies, and many degrees of freedom, particularly because patients need to be so engaged in their care in the outpatient setting. So, you know, in the hospital, again, if I order a medication, the patient gets the medication. I order a test, the patient gets the test. In the outpatient setting, there's a lot more that has to happen for those, for the medication to be picked up and taken as prescribed, or for the test to actually get done. So this is where I think safety and population health are so intertwined. As we've thought about ambulatory safety, and again, mostly this comes from primary care data, though many of these issues are relevant across all specialties. The top areas in ambulatory safety have been medication safety, transitions of care, and missed and delayed diagnosis. And these are all critical if you're thinking about managing populations over time. We have to understand, you know, medication safety, and do they know their medications, and are they taking their medications? Patients who are, you know, coming in and out of, whether it's a rehab or whether it's the hospital or whatever, we need to make sure information is flowing seamlessly, and making sure that we are actually making the correct diagnoses. I say this is just the tip of the iceberg because, again, these are not the safety issues in a dialysis center necessarily, or in a nursing home. So we need to learn a lot more about what we have to focus on in those settings. We have a really interesting project actually that we're doing right now about what are the safety issues in the home. Really critical, again, as you think about chronic disease management. You know, we're asking patients to do a lot of things in their homes now, and what are the safety issues there for themselves, for the patient, and also for caregivers in those settings, if you think about, you know, managing patients with dementia, for example. So, so that's a new area that we're really interested in, and hopefully we'll be learning a lot more about. So just a few stats. I had to do a few research data slides. So medication safety in the outpatient setting. This is a relatively old study, but still probably one of the better ones on primary care. Adverse drug events are common and often ameliorable, 25% in one study. And so what do I mean by ameliorable? That's this whole issue of the medication was prescribed correctly, patient had a problem, and the problem lasted a long time, basically due to lack of communication with the provider. About, you know, the patient didn't call, or they told the provider and nothing was changed, even though alternatives were available. So that was a new term. In the hospital, ameliorable never even came up. But in the outpatient setting, we saw a lot of these ones that were just lingering for long periods of time. And then we know that there are, in the past at least, and I'll talk about this more when we get to technology, but you know, handwritten prescriptions had a significant error rate. In this one study, 8%. We've seen ranges from 8 to 40, you know, to 40% of errors in handwritten prescriptions. And electronic prescribing is a great example of a technology that we think has had a significant impact on prescribing errors. A couple of small studies that I list here that showed error rates reducing from, I mean, this first study had that 40% rate down to 6%, and then 18% to 8%. So, you know, thinking about tools that can actually have impact on some of these issues. Non-adherence is another really important issue, and hasn't really been talked about as much in safety as I think it needs to. And this, again, really ties into chronic disease management, caring for populations, et cetera. Because if we aren't thinking about this issue, we're not going to get to, you know, the control of these conditions that we need. And this particular study at the top is what really got my attention, which was, you know, there's been lots of statistics about non-adherence, but for whatever reason, this one really drew me in, which was about 200,000 prescriptions, and only 72% were filled. So 1 out of 4 not filled at all. And it wasn't for your PRN steroid cream for the rash that went away. It was for medications for chronic conditions such as hypertension, diabetes, and hyperlipidemia. So we're really going to need to think about, I mean, the safety implications of this are huge, especially because often we think patients are taking these meds and they're not, which ties into medication reconciliation and all kinds of things. But then it also leads to polypharmacy, where more medications are added instead of understanding that these medications aren't being taken, et cetera. So there was a nice editorial in JAMA about medication non-adherence as a diagnosable and treatable condition. Yet we're not very well trained in how to diagnose and treat it as clinicians. And really bringing in the patient to understand their beliefs and values, understanding what trade-offs they're willing to take, et cetera, is really critical. And so, you know, to me, this is an area that needs a lot of focus as we go forward. Okay, so that was medication safety. Transitions of care. We've done, most of the research in this area is hospital out. So hospital to home or to rehab, basically. And the research has focused on reducing readmissions and those kinds of things. But the initial research was to identify that this is a really high-risk period. Hospital out, very high risk. There are 30 days post-discharge, adverse events that occur, medication issues, test results that fall through the cracks that were pending in the hospital and then no one follows up on, and unresolved medical issues. So, you know, a person in the hospital who had Guaiac-positive stool needs outpatient colonoscopy, and then do they actually get the colonoscopy in the next 6 months? Those kinds of things. And lots of studies that show a lot of these things don't happen. I would also argue that we need to learn a lot more about other transitions. So, you know, rehab to home, how does that transition go? Or nursing home to emergency department. I know when I was at Partners, that was a big pain point for us, where patients came from nursing homes to the emergency department and we wouldn't get any information about anything. And we're trying to kind of figure out what meds the patient was on or those kinds of things. So as much as we have focused on hospital out, I think we need to think about all these other transitions and what are the strategies that are going to work to improve those as well. We also have gotten some good data on what can actually help. So standardizing templates for transitions, improving the discharge process or the handoff process. We did a lot of work with warm handoffs. So if a patient was going to rehab, having nurse-to-nurse telephone communication rather than just sending the patient with you know, a stack of papers. Improving safeguards for that post-discharge period, so follow-up phone calls, follow-up appointments, maybe a follow-up conversation with a pharmacist with a high complexity medication regimen, medication reconciliation, et cetera. There was a study that actually showed that if you call a patient 3 to 5 days after discharge, about 1/3 of them are doing something that's different from their discharge med list. So if you think about all the time we spend on inpatient medication reconciliation to try to get that med list perfect at discharge, and then within 3 to 5 days, something's happening differently. So we really need to manage this high-risk post-discharge period. All right, and the third area in ambulatory that I want to highlight, this is kind of the hot area in patient safety, I would say. And this is the most common type of ambulatory malpractice case, which is missed and delayed diagnosis. Most often missed cancer, most often occurring in primary care. If you look at kind of where breakdowns occur, if you look at these kinds of missed and delayed diagnoses, failure to order turns out to be the top breakdown area, followed by maybe not an appropriate or comprehensive history and physical, and then failure to interpret tests correctly. There's patient factors as well, patient adherence to the plan, a few different areas where things break down. The key thing to realize is the number of breakdowns per case is about 3. So it's not a single point failure, it's a typical safety Swiss cheese, multiple things that can go wrong. So the question is, how do we prevent these? And this is a very challenging issue. You know, failure to order is really challenging because how do we get someone to think to do something? And the answer is not going to be, well, you know, try harder, think better, we'll do more education and training, because we know that's not going to be highly reliable. Human beings make mistakes, and in the interrupted environments we work in, the complexity of where we work. If we rely on that, we'll still have things that don't get diagnosed correctly. So how can we think about systems to help reduce cognitive errors? And you know, there's a lot of talk about technologies and other things that will help, so we don't know the answer yet. But there is a lot of conversation about how we could use technology. So, you know, you could pull data from throughout the EHR into one place around a particular issue to highlight certain things, or you could have you know, decision support algorithms. For one example, in the partner system that we did it for was breast lumps, because we were finding that a lot of times the right test wasn't getting ordered, and so you build the algorithm right into the workflow to help clinicians order the right test. And in addition, strategies to reduce systems errors. And again, these are foundational systems that are going to help no matter what you're trying to do. You're trying to manage diabetes, you're trying to manage you know, a surgical population, whatever it is. If you don't have a good test result management system or a referral management system, you're going to have things that fall through the cracks. So what do I mean by closed loop test result management? Is every test that is ordered acknowledged, and the patient sees the result, and if there's an abnormal, that gets followed up. And you know, if you look at data, about a third of tests that are abnormal don't get appropriate follow-up. So we have a lot of room for improvement on test results, and referrals is similar. You know, do you have a referral process where when you refer to a specialist, you know if the patient goes or doesn't go, and you make sure, and you know you're going to get the information back in a way that then you can react once they've seen that specialist? And I would say, again, most organizations don't feel like they've got that to a high reliability level. It's often, you know, people on the team having to track it down and figure out, well, what happened with that referral. So, so these are foundational safety systems that, again, I think are really intertwined with whatever else you are trying to work on from a quality improvement standpoint. I just want to mention this report that came from the National Academy of Medicine, formerly the Institute of Medicine, in 2015. It's, I don't know, over 200 pages maybe, on diagnosis error. So if anyone has a really burning interest in diagnosis error, this is a great report that will tell you more than you ever wanted to know about diagnostic error and how we might come up with strategies to prevent it. And as I said, this is really kind of a hot area in patient safety right now. So the other thing I want to highlight is in the outpatient setting particularly is infrastructure. And you know, we're talking a lot about patient-centered medical home, about team-based care. If we want to really have effective teams in these ambulatory settings, again, with various people of various backgrounds working on you know, registries or managing populations or diabetes management or whatever it might be, this is a foundational piece. You know, do you have, what is your culture in your practice? Are people, you know, is the medical assistant able to speak up to the senior clinician if they think something is not correct? Do they think they're going to be punished if they make a mistake? So culture in ambulatory is as critical as it is in hospitals, yet most organizations haven't really focused on that. And there's tools to measure it. The AHRQ instrument that I mentioned earlier, there's the version for ambulatory practices. So taking some of the principles that we've been working on in hospitals now for the last 15, 20 years and moving them to ambulatory is going to be really critical. So what's your culture so that those teams can work effectively? Do you have ways to report issues when they come up? And do you have people who can look at those issues and analyze them and think about system improvements? That expertise is often lacking in ambulatory settings. And are you thinking about things proactively, again, instead of reactively? Are you sort of identifying where do you have risks? You know, do an assessment of your test result management system and see, like, how reliable is it? And do that proactively as opposed to waiting for that bad test that falls through the cracks that led to the malpractice case and then fixing it. You know, try to think about those things proactively. And this is really, as I said, for all outpatient settings, not just ambulatory practices. So thinking about the whole world of healthcare outside of hospitals. Okay, number 6. This one sometimes surprises people. So this is support for all of you. Workforce safety, morale, and wellness are essential to provide safe and high quality care. So professionals, healthcare caregivers need support to do the work that we all want to do. And so we need to pay much more attention to physical and emotional harms to the workforce. In addition to providing kind of ongoing training and education opportunities to kind of continue to give joy and meaning to the work we do, to give us the tools we need to do our jobs better. So this whole term about joy and meaning, these are not sentimental notions. And there was a report that came out from NPSF before I even got to NPSF called Through the Eyes of the Workforce, Creating Joy, Meaning, and Safer Healthcare. And I remember when I saw the title, I was like, well, that sounds kind of squishy. This was a while ago. This was in mid-2000s or late 2000s. And then I read the report, and a light bulb went off. I'd been working on patient safety for my whole career at that stage, and had never really thought about workforce safety. I'd been thinking about patient safety. And what the argument in the report is that workplace safety is inextricably linked to patient safety. And unless caregivers are given the protection, respect, and support they need, they're more likely to make errors, fail to follow safe practices, and not work well in teams. So, you think about if you had a choice to be in 2 ICUs. In one ICU, the staff were really burnt out. There was a lot of physical harm, back injuries. They were having a lot of disruptive and disrespectful behavior. And then there's another unit where there's great teamwork, communication, not a lot of burnout, very little physical harm, very respectful behavior. Where would you rather get your care? It's very linked to the care that then goes down to the patient. This is the report that I mentioned, and all the reports I mentioned are on our website, except for that National Academy of Medicine one, which is on their site. So these statistics tend to, again, surprise people in healthcare. Healthcare workers suffer a lot of harm, emotional harm, like bullying, demeaning, disrespectful behavior, burnout, and I'll talk a bit more about that. Physical harm, injuries, workplace violence. Up to 1/3 of nurses experience back or musculoskeletal injuries in a year. No other industry would tolerate that level of injury to their employees. And actually, here's the data to prove it. It's very small, but all you need to know is that top graph, blue is sort of the US average of physical harm, and red is healthcare. Healthcare is, if you look at some detailed statistics, the healthcare workforce injury rate is 30 times higher than other industries. We are more dangerous than mining, manufacturing, construction, any of these types of fields that you would expect to be dangerous, and healthcare is worse. A nurse or a physician has a 5 to 6 times higher chance of being assaulted than a cab driver in Seattle. And what's sad too is we've normalized this. This is just, well, that's how it is. Yeah, I work in an ED and I, might get hit or that other clinician, is always disrespectful to me and I just deal with it. So it's become very normalized and we have to break that cycle. Psychological harm is a really big deal. Lack of respect, support, appreciation, non-value add work. I know we can all appreciate that. Poor design of work environments, poor workflows, all of these things that then contribute to burnout. I put a lot on this slide, so I don't want to walk through all of it, but there's a lot of focus right now on this issue of burnout. Rates of burnout amongst US physicians, nurses are increasing. Prevalence is growing and satisfaction with work-life balance is decreasing, and it's increasing more rapidly among physicians than the general population, and particularly in primary care. Factors contributing to burnout, a lot of things I just talked about, stress, disillusionment, loss of meaning. Technology has been cited as a significant factor leading to increased burnout as well, and I'll talk more about that in a bit. So what can be done? And the really important point I want to make here is there's been a lot of work around individual resilience, and I think that's good work to try to build up people's individual resilience. But you could be the most resilient person, and if you're working in a horrible system, you're probably not going to survive without a little bit of burnout. So we need to think about system-wide improvements to things like respect, workflow, technology, et cetera, to address this burnout issue. It can't be, you know, oh, clinicians just get more resilient. So this is going to be, I think, you know, a big issue. And how does this tie to everything else? It ties because if you've got burnt out clinicians, trust me, when you walk on the floor and you say, hey, let's work on a safety project, they look at you like you're crazy. Or, hey, let's work on population health, and they're like, I cannot do one more thing, leave me alone. So this is critical to accomplishing all the other things that we're trying to accomplish, is we're going to have to address this burnout issue. Okay, and I put this in. These slides, by the way, I can share. The one thing that I like this study because it went to 23 primary care groups and said, who are the kind of high performers that had less burnout? And they found systems things that they thought highly correlated with the reduced burnout. And it was, you know, having more multi-provider teams, better teamwork, reducing non-value added work for the physicians, having pre-visit planning to free up time during visits by doing a lot of stuff between visits, those kinds of systems things that actually led to decreased burnout. This has a lot of cost. As I said, no other industry would tolerate the physical harm that we deal with and the psychological harm and burnout issues. There's a lot of cost with lost work hours, with turnover, inability to attract new people to these fields, and in addition to those costs, increased opportunities for medical errors and impact on patient experience as well. It's hard to be, we've done some partnership with the Schwartz Center, which works on compassionate care. They're really interested in burnout. We're interested because we think it impacts safety and medical errors. They're interested because clearly burnout impacts compassion and empathy. So it's really one of these things that has impacts across all of healthcare. Another thing to just mention, and I'll hurry now, think about the positives. Don't just focus on the negatives. We've got a burnt out clinical staff. When you're thinking about safety or quality, maybe highlight a case that went really well, as opposed to always the cases that didn't go well, and think about what can we learn from the cases that go well, because that, I think, is a strategy that might help alleviate some of these burnout issues as well. So at the National Patient Safety Foundation, we think this is so important that we, our vision is creating a world where patients and those who care for them are free from harm, because we do think this is preconditional to patient safety. All right, number 7, partnering with patients and families. And this is really about patient engagement at all levels of care. That's essential for safety, essential for population health, chronic disease management. We need to have partnership with patients around their treatments, their understanding of their disease. Studies link patient engagement with satisfaction, safer care, improved work experience for caregivers. If you have more engaged relationships with your patients, it actually helps with burnout, and better health outcomes, which is what we're all striving to achieve. Another report from NPSF on patient engagement, but I just want to highlight, it's really about asking patients what matters to you, as opposed to what's the matter. Really understanding patients' goals, patients' preferences when thinking about treatment decisions, and then encouraging patients to speak up, to ask questions, and actually not be threatened to do that. So, you know, we have a lot of work on this front. One of the things that we really focus on is having patient engagement at all levels. So do you have patients and families involved? At the sharp end, do you have good, as I said, shared decision-making strategies? Do you have good disclosure, which I know you have here, good disclosure about medical errors? But then at the practice level or hospital level, do you have patient-family councils? Do you involve patients in quality improvement efforts, in safety efforts? If you're redesigning a process, get the patient voice in that redesign. And then we talk about it at the national level too, if we're thinking about metrics or research or other things, have that patient voice there. And so it really needs to be embedded into everything we do, as opposed to us deciding what's best for patients. Have the patient be part of that process, sharp end all the way up to the national level. And so here are some tools that health systems are using to do this, and I've kind of touched on a lot of these. So I won't talk about those. And, oh, the last thing I do want to mention, and then what's the message to patients? And a lot of times people think patient engagement and safety is ask me if I've washed my hands, which is not what we're talking about. You know, I get into trouble saying this, but that one drives me crazy because it's really not my patient's job to make sure I wash my hands. It's my job. And so, though we still as patients have to do that, but it's really about engagement. Understanding risks and benefits. Don't go alone to your hospital visits or your doctor's appointments. Make sure you have someone with you. Know your medications. Know your plan. These are the kinds of things that I think to manage the care of patients over the long term, we're going to have to really encourage that level of engagement of our patients. All right, last but not least, technology. So technology has proven potential to improve patient safety, but only if we can minimize the risks. And we have lots of technologies that we think have value. Computerized order entry, barcoding, e-prescribing I talked about, tools for handoffs, test result systems, even population health tools, and the new analytics that are coming along. And the question is, how do we optimize these? Because we think all of these have value. We're investing lots of money in them. I was one of the researchers who sort of wrote some of the studies that said, hey, these really have good impact on safety and quality. But if we don't implement well, we may not get those benefits, and we're going to get all kinds of new unintended consequences that we maybe haven't even anticipated. So this is all about design and implementation now, and how do we implement well, making sure we're not over-alerting and driving people crazy, making sure there's interoperability, kind of new problems that we have created, how are we going to solve, like copy and paste, which I could spend an entire hour talking to you about. Even accurate medication and problem lists, as we're trying to think about, analytics and registries and other things, and how do we make sure the data is even there and in a way that's usable and that is not driving our clinicians crazy to turn into data entry, spending more time on data entry than talking to patients. These are all challenges we're going to have to solve over the next few years if we're going to get the value from IT that we really want. So, another example of unintended consequences, this is back to electronic prescribing. I said it reduced prescribing errors, but guess what? It also introduces new errors. And it depends on what system you buy. You could buy one system and it introduces a few errors, and you buy another system and it introduces a lot of errors. So that's the kind of thing we need to understand and get rid of, that variability, but also just these new errors that are getting introduced. And as I mentioned, this is a big source of burnout. This was not the goal of implementing electronic health records, to create more burnout for clinicians. So we're going to need to do a lot of work to improve the usability and workflow piece so that these tools, again, achieve what we want without creating these new problems. Okay, so I'm going to skip through some of this stuff. There's a lot going on at the national level around EHRs and improving design, et cetera, but I think we're at the really early stages of this. And if we're going to use these tools in our workflows to manage populations, to improve safety, to manage test results, whatever it is, we're going to have to see better systems and better implementations. All right, so I've talked a lot about how we've improved in safety, but still we have a long way to go. And it really needs to be a core to everything else that we're doing. Those safety foundational systems are going to be core as foundations for the new work that we need to do. I've kind of walked through 8 recommendations that outline a framework for how we can hopefully accelerate our efforts to create a world where patients and those who care for them are free from harm. So thank you for your attention.
Really outstanding presentation, Tejal. We have a few minutes for questions. Any questions for Tejal? Yeah.
I'm just curious, if you could focus your research on one thing that I have most impact, where would it be? Would it be provider? Would it be?
So for folks joining remotely, the question was, where would you focus your research to have the most impact?
You're going to make me pick from my 8, huh? Honestly, and this is actually what work we are doing at NPSF, I think that the cultural piece is really critical, and I think the cultural piece actually spans some of these others. So we talk about a culture of safety, and that includes trust and respect and other components, which then ties into the burnout issues and other things. So to me, if you don't have that culture where people feel respected, where they feel comfortable talking about problems and issues, where they can speak up without fear of retribution or you know, getting yelled at or whatever, to me that culture then drives everything else. And that's a tough one to work on. That's you know, the culture changes 5 to 7 years type of stuff, but to me it's really foundational.
Yeah.
You mentioned your family member is getting a total knee replacement. You could have it your way, and you know, have any information that's available to you that you wanted, but that would be a surgeon decision whether your family member should have surgery with them or not. What would you choose?
So the question was, what information would Tejal ideally like to have to make a decision about what orthopedic surgeon to operate on her family member?
It's a great question. Well, first I want information about the hospital that that surgeon is working in and the practice. So I'd want to know about, you know, infection rates for the hospital, volumes of the hospital, et cetera. And that data you can get with some digging. I'd want to know what the culture is in that hospital and what the culture is in the practice. And again, the practice is so important because a lot of it is now, you know, you're in the hospital for a day, but then there's this, you know, several months of recuperation, and you're often seeing a PA or you're seeing other people, physical therapy. And how is that team communicating? How does that team communicate with the surgeon? Is there a hierarchy, or are they really a team? I mean, that would be information that to me would be pretty critical. I'd want surgeon-specific outcomes and infection rates as well, which is really hard to get at. You know, you can ask the surgeon, they, oh yeah, I have great infection rate. Well, but what is it? So that's, you know, I'd want long-term patient-reported outcomes, return to work, pain scores, those kinds of things. I mean, that's a lot, and I, you know, because I'm who I am, I can think of all that. The typical consumer may not want all of that, but honestly, they'd want, well, when can I get back to work, and when am I not going to have pain? Would be good, solid outcomes data that I think would be valuable for that practice and surgeon versus another. So that's the level that I think we'll be trying to get to, and it's going to take us a while. But that's how I think people can make more educated decisions.
Do you think there's a possibility of unintended consequences with some of those things? You know, culture is difficult to, you know, change into numerical values. Outcomes can be influenced by many factors. A person who's in an urban mixed practice versus someone who chooses to see, you know, people who are more affluent and have more resources, their outcomes might be different. It might be an unfair comparison. How do you address those problems?
Yeah, and I think, I mean, the outcome stuff, and obviously risk adjustment and other things are key things that we need to think about when we look at outcomes data. You know, I think culture, you can actually get a reasonable sense from the surveys that are out there to quantify. There's always going to be unintended consequences. I guess my feeling on this is, right now we're in kind of a no data state, and I'd rather be in the, we have some data and we then have to address the unintended consequences, as opposed to right now where we're literally, you know, doing it because my neighbor said they're good.
Dr. Gandhi will be here all day and has a few minutes more before we whisk her off to her next meeting. So if you have questions, why don't you come up front, and let's thank her again for an outstanding presentation.